Start the recording, and we'll go ahead with introductions.
All right. Well, hello, Bonjour, Anine, and welcome to the Cancer and COVID-19 Survivorship discussion. My name is Kris Rhodes. My family and I are from the Fond du Lac and Bad River bands of Lake Superior, Chippewa. As the director of AICAF, I want you to know that AICAF, or the American Indian Cancer Foundation, remains dedicated to our mission of eliminating cancer burdens Indigenous peoples face while maintaining our commitment to reducing the spread of coronavirus. Today's webinar is part of a series of chats with leading experts across the nation where we address Indigenous health issues related to cancer and COVID-19. We want to thank each and every one of you for taking the time out of your day to join us in this conversation. And we'll leave some room at the end for questions at the end of the discussion. So please do submit questions in the chat box or in the Q&A box, and we'll be sure to address them. And if we are unable because of time, we'll follow up. So today we are joined by Dr. Andrew Badley. And Dr. Robert McWilliams from the Mayo Clinic. Dr. Andrew Badley is the medical director for the Mayo Clinic COVID-19 Taskforce, and Dr. Robert McWilliams is the vice chair of the Mayo Clinic Department of Oncology. I really want to thank you both for joining us today for this important discussion about what's going on in the world and how our Indigenous communities can come together and support one another during this COVID-19 pandemic, and where Mayo is with all of this. Our format today is that there's going to be a presentation, or two presentations, right? And we'll be managing the questions after that, and but we're ready to go forward with a presentation. And I don't know if we want to do additional introductions. You could certainly do that as you get started. And I want to also remind you that people that are joining us live Facebook streaming option can also ask questions in the comment section.
Great. Shall I go first, Jenny?
Please.
Great. So thank you all for inviting me today. It's my pleasure to be here. As mentioned, I oversee the research task force for COVID-19 at Mayo Clinic. My background is I'm an infectious disease clinician. So I've been thinking about viruses and how viruses affect people for the past 30 years or so. So when COVID became an issue within North America and for us at Mayo Clinic, research leadership asked me to chair this task force. And we were really overwhelmed with the prospect, as everyone else was, of the projected number of cases that we were going to get. We had no idea how to treat it. We had no idea how sick people would get. And so we put together a large group of people to help advise us on that. And I like to make comparisons to how we responded to COVID compared to how we responded to AIDS 30 years ago. And at the beginning of the AIDS outbreak, we didn't know what the virus was. We didn't know the biology of the virus. We didn't have any drugs that we thought could impact the virus. And it took a decade or more to get our hands on all of those things. In comparison, where we are with COVID is within weeks of identifying the syndrome, we knew what the virus was. Because of sustained biomedical research funding over the past decades, we already knew a lot about the virus and related viruses. So we knew the protein, so we had some very good ideas of what drugs could be used to treat the virus. And so very rapidly, we were able to initiate clinical trials. To date, last time I looked, there were over 1,500 clinical trials being proposed or run to treat COVID patients. And so our approach is we want to be very thoughtful and careful and selective about what trials we do. And so broadly speaking, there's two kinds of treatments for COVID disease. The first kind of treatment is drugs which target the virus, and their proposed role is to stop the virus from replicating. And if you stop the virus from replicating, hopefully you'll stop the symptoms associated with the virus. And the drug that you've heard the most about in that space is remdesivir. It's been all over the news. There's been reports about it. And I think it's fair to say that consensus is it looks like it has activity against COVID disease, and it can shorten the duration of symptoms and reduce the number of people who get critically ill. And so already within 3 months, we have very, very favorable antiviral activity from this one drug. There are multiple other drugs that are in development and being tested for COVID disease. And those clinical trials are ongoing. We also know that for other viral diseases, having more than one antiviral is better than having one. And so in the case of HIV or hepatitis C treatment, we often treat people with 2 or 3 different antivirals. And in my opinion, it's probable we're going to find that 2 or 3 antivirals is better for COVID disease. So already we're starting to look at combination therapy, remdesivir and other agents to help block viral replication. The second class of drugs that we use to treat COVID disease are called immunomodulators. So to explain that, we have to take a step back. And to take that step back, why is it that having a virus in your body is bad? The virus itself doesn't, cause illness, but what does cause illness is the host response, the response that you and I and others would make when we have the foreign virus in our bodies. And that induces what's called an inflammatory response. And it's the inflammatory response which gives us fever and chills, which is good. And that means we're fighting the virus. But sometimes that inflammatory response can get too big and too great. And that's when you get very sick and have to go to the intensive care unit and can require support for different organs. So you can be on a ventilator for your lungs, or you can be on dialysis for your kidneys. And so there's a large group of compounds that are being tested in the clinic right now to block that inflammatory response. Those drugs have been less well advertised on the media, although I think you're going to start seeing more and more reports of those. 2 of those drugs that have been tested, and we're starting to get early data from clinical trials about, are drugs like tocilizumab, which is a drug that blocks IL-6, which is a inflammatory mediator in the body. And there's another drug called linzilumab, which is in clinical trials, which targets a different inflammatory mediator. And I think we'll see that there's some evidence that this approach to therapy can work. So I mentioned we're starting some trials using both multiple antiviral compounds. There's also at least one trial started, and I'm sure others will follow, looking at combinations of antiviral agents plus anti-inflammatory agents. And one of those is being started by a group called NIAID, which is the group that Dr. Tony Fauci oversees. And that trial will involve remdesivir plus a anti-inflammatory medicine called a JAK inhibitor. The other thing that people want to talk about is vaccines. And let's take a minute to talk about what a vaccine is and what its promise may or may not be. So a vaccine is to take a part of the virus and put it into humans and hope that that drives an immune response. And that immune response is possibly going to protect people from getting infected with that virus in the future. Now, we've done vaccines for hundreds of years, and there's really 3 different kinds of responses to vaccines. So some viruses, like measles and polio, if you do what we just said, you take part of the virus and put it into a person, they develop an immune response, and that is nearly 100% protective against getting subsequent disease. But if you do the same thing for diseases like HIV and hepatitis C, you get a lot of immune responses, but they are not enough to protect you from getting infected. So they're 0% protective. And then finally, there's another group of viruses which falls somewhere in between, where you can get an immune response, and those immune responses are partially protective. And examples of that are influenza. So influenza vaccine, depending on the year, is roughly about 60% protective against getting disease. So what we know so far in the vaccine field for COVID is that there's a lot of vaccines that are being tested or soon will be tested. And by the last count, there was about 175 of these vaccines. We know that the early reports from some of the clinical trials show that they develop that patients who receive these vaccines have an immune response against the virus. But what we don't know is if that immune response is protective against the virus. So more and more clinical trials are starting and will be starting to measure those two elements. One is, can it induce an immune response? And two is, will it be protective? We should get answers on the immune response part within a relatively short period of time after the studies start. And the second question is, will that be protective? And that's going to take a much longer time to figure out. My guess is it's going to take a year or more after the trials have started. So that's kind of a summary of where we are in the development of therapies. In addition to the development of therapies, there's all kinds of research going on around COVID. So key elements of those research are understanding the virus itself, understanding the immune response to the virus. We're putting together databases which allow us to understand how different patient populations and different groups of patients respond. We know that the virus disproportionately affects some ethnic groups compared to others, and that's of critical importance. So we have a group that's working on that. The focus of their work right now has been mostly education, reaching out to those communities to educate what's going on and what studies are going on. And Jenny Weiss is intimately associated with that. We have studies of remote monitoring that if you're infected with the virus but not yet sick enough to need to go into hospital, we have ways of monitoring you remotely to determine if you're starting to get sicker and sicker and whether or not it would be appropriate to move into the hospital for care. We have studies looking at how to decontaminate the environment, how to refresh masks, for example, so you continue to reuse masks. And we have studies on the genetics of both the virus and the person to see if there are genetic factors which predict outcome. So that's really a summary of our activities here at Mayo Clinic on COVID and COVID-related activities. And we will be happy to address some comments and questions moving forward. I did see one question coming across already, which is, what is the access to remdesivir? So like any good question, it leads to a complicated answer. And so the complicated answer here is remdesivir has been through about 4 clinical trials. Those clinical trials have closed and we're learning reports of those. Because it is showing evidence of activity, the North American supply of remdesivir has been coordinated by the federal government. What the federal government has done is it's been given about 960,000 doses of remdesivir. It is asking every state to report roughly weekly how many cases they have, how sick the patients are, how many are in the intensive care unit. Based upon that information, the feds then ship a different amount of drug to different states according to their density of disease. When it arrives in the state, each state has a different process for allocating drug. In Minnesota, that process is the number of patients that you have in the intensive care unit who are critically ill determines how many doses you get. As I say, this happens weekly, and so it's a constantly moving target. Unfortunately, we do not have enough doses of remdesivir to treat everyone we would like to treat. So we're targeting it now for the sicker patients. What's going to happen in the future, we don't know. We believe that the company that manufactures remdesivir, which is Gilead, is asking for regulatory approval to sell this as a prescription. If and when that happens, then we will shift to a prescription-based allocation. So that's the latest on remdesivir.
I think maybe we'll pivot to Dr. McWilliams then. Thanks, Dr. Badley.
So I'm Dr. Rob McWilliams. I'm a medical oncologist at Mayo Clinic in Rochester, Minnesota. I primarily treat GI cancers and melanoma, but I'm also chair of our clinical practice committee of our Mayo Clinic enterprise-wide. So as Dr. Badley well pointed out so well, we really knew very little about this virus, this COVID virus, when it first came. But what we did know is it was coming quickly, and we had to develop plans to deal with it. So one of the main things I did was trying to make sure we had a forum to be able to communicate with all our various cancer treatment sites and with our different specialties as well. So we have sites in Florida, we have sites in Arizona, across the upper Midwest, and we have many different specialties involved in cancer care, surgery, radiation oncology, medical oncology, hematology, among many others. And so we put together a forum to have discussions. And as most people experience with this, things change with day to day. The rules changed, the knowledge changed. We've had studies published and then retracted. And so we're learning from this. We're trying to learn as much as we can and track our experience with cancer and COVID as we go. Early on in February, some of the initial reports were coming out of China that suggested that patients who are cancer survivors and patients with active cancer may be at higher risk for complications from COVID. So that got our attention right away. And as we thought about lowering risk for our patients and developing plans, that was really first and foremost part of the conversation of, are cancer patients at higher risk? And then among those, who's at higher risk? There's not all cancer patients are alike, and you might define populations in many different ways. A cancer survivor could be someone who had a breast lump removed 20 years ago versus someone who's undergoing an allogeneic bone marrow transplant tomorrow. And so there's a very wide spectrum of what we thought would be likely people to be susceptible to the inflammatory complications of COVID versus patients who may be at average risk or at least a comparable risk to the general population. The other thing is, even though other aspects of our clinical practice could take a back seat and we could pause some things, elective surgeries could be delayed, cancer doesn't take a holiday. And so we knew that we would have to develop plans to be able to maintain patients' cancer treatments throughout the height of the crisis. And as time goes on, and as we realize it's going to extend for a longer period of time, I think thinking about that and thinking about long-term makes sense. And we've been doing that quite a bit. So we had risk. We're trying to define who's at risk, and then we had mitigation strategies, and finally we're trying to think about how we can make lemonade out of lemons and try to learn from this experience and try to improve things going forward. So with regard to risk, there's been multiple clinical articles coming out, and we've looked at our data as well. And with the populations that seem to be at highest risk are patients with profound immunodeficiency. So those with hematologic cancers, leukemias, people going through bone marrow transplant who have very deficient immune systems, seem to be very population of very high risk for complications of this. The other populations are people who are who have other risk factors as well. So people in the ages at risk, 80, 90 years of age, who have multiple comorbidities, diabetes, or other high blood pressure, other risk factors for complication from COVID. Cancer affect those populations too. So we need to be cognizant of that. We also think about types of treatment. So we have ranges of therapy from classical chemotherapy to bone marrow transplants. We have immunotherapy and targeted therapy and CAR T, and so how do we get our minds around all of that? We've also been talking with other cancer centers through the NCCN, the National Comprehensive Cancer Network, to try to all learn from each other as we kind of go through this crisis. But right now, what we are doing is trying to mitigate the risk for all of our cancer patients as much as we can. So a lot of centers around the country are doing similar things, but what we've been doing specifically is, again, following the national guidelines. There's guidelines from ASCO out there and NCCN, among other recommendations to CDC for masking, for following our governor's guidelines for social distancing, and then also trying to limit exposure and risk when patients are in our campuses or in our hospitals limiting visitor policies. For instance, for a while we weren't allowing visitors in the inpatient setting at all, and now we're allowing one. In the outpatient setting, we've limited visitors to one, which can be challenging for our cancer patients. I think everybody gets a lot of support by having families with them and loved ones, but people have found creative ways to do it. So sometimes one visitor will be there physically, and then someone else will be on FaceTime in the visit and be able to listen in and ask questions. So our patients have been pretty resilient, and we as providers have been as accommodating as we can be under the circumstances. We also social distance in our waiting rooms, and trying to thin out the number of chairs or where people can sit, and limiting exposure. When people walk in our buildings, we're screening for symptoms. We have people stopping them and saying, do you have a cough? Do you have a new fever? There's a list of questions they get asked to get their temperature taken. So all these things to limit the exposure that our patients get, so they're not fearful when they come to get the treatment for their cancer that they need, that they're going to then increase the risk for exposure. We've been creative with video conferencing and phone visits as much as we can, although we realize that really doesn't replace the treatment that our patients need. And so, we can do certain types of visits on that, second opinions, or sort of checks and see how people are doing. But in general, for active care, people physically just need to come to the facility and get their treatment. So again, trying to minimize any exposures at that time. We've been one of the few centers testing all of our patients who are getting chemotherapy and radiation therapy for COVID. We test whether patients have symptoms or not. Other centers are focusing more on the highest risk people, like bone marrow transplant patients or leukemia patients. But we found people who feel well, look well, can carry the virus as well. It's not real common, but it does happen. And to minimize risk for exposure, we have chosen to test our folks. So we realize that that's a resource question that may not be available everywhere. But it's certainly trying to minimize the risk of people while they're here, limiting people in the treatment areas as well. We're fortunate to have just remodeled our treatment area all three of our main campuses recently, and so we had much more individualized space where people aren't exposed to other folks. Other centers are having to scramble a little bit more and trying to space people out a little bit more than they might have historically been to try to maintain that social distance. But it's an ongoing effort. It's an ongoing learning curve for all of us. We're actively trying to track our patients and on a day-to-day basis, and have almost a dozen physicians involved in this effort of literally just tracking the testing, seeing how they're doing, looking at outcomes, and trying to then learn from that and understand about who is at highest risk. Are there strategies that work better than others, and what should we keep doing, or what should we stop doing, what should we start doing? There are some national groups. Vanderbilt started one, but there's others as well. Several of the societies are trying to pool our data, and so there's a lot of volunteer efforts of cancer specialists across the country pooling information to then more rapidly make these advances in the understanding of how we protect cancer patients, allow them to get the treatment that they need, and also are able to kind of minimize the risk. For a while, some of our more procedure-based treatments, so surgeries, things that were high risk for transmission of COVID. So procedures where someone had to get a breathing machine or had to be on a ventilator. We shut things down for a while, and that was very upsetting for a number of our patients to have to say your cancer surgery, which you need, is going to be delayed until we can learn how to do this better. And Dr. Badley and our surgical colleagues and our multiple other people involved were very helpful as trying to study that and say, okay, to minimize risk to people in the operating rooms and the procedure areas, what do we need to do? What strategies do we have to do? And he mentioned some studies that they're doing, and we look at airflow and virus transmission and that. And so we think we have as safe procedure as we possibly can to minimize risk to patients when they're there. We test them before major procedures. Do you have the virus or not? And then still try to minimize any potential transmission through protective equipment and the distancing that staff do, trying to leverage technology, video into patients' rooms when you don't have to physically go in, things like that. So there's a lot of changes in a very short amount of time that we've all undergone, and yeah, we're still learning as we go. But you know, cancer patients are resilient, and they've been very adaptive and do what needs to be done. And I think we're all kind of working together to make sure the patients get the care that we need. So I'm happy to answer any questions or explore things a bit more.
There was a question that came earlier in the week, noting that children typically do better with COVID-19, and we've seen that play out. But do pediatric cancer patients do better than adult cancer patients if they contract COVID? Or is it an evening out?
You know, I don't know that we have the numbers to really report that. There's not been large pediatric studies reported because there are much fewer patients. They do tend to get these leukemias or can undergo transplants. So there is that subpopulation of those with those cancers that can be at very high risk and need to be very cautious as far as their exposure. Patients in that setting are, you know, socially isolated, not going out, that sort of thing. We also know that the risks in the general population, so age and other diseases, comorbidities, do track for cancer patients as they do for adult patients. So, you know, aside from that group that's very immunosuppressed, I mean, I would think that you know, pediatric cancer patients that are not going through a bone marrow transplant or have leukemia would be at lower risk. But we are messaging to all of our cancer patients that we think they're at higher risk than average people and need to, you know, very, very much follow the precautions and limit their exposure during this time. So it's one of those things we prepare, we, you know, be as cautious as we possibly can, at the same time reassuring that, you know, for patients not profoundly immunosuppressed, that they're probably comparable risk to average patients.
So only one little thing to add to that. So a number of therapies that are already used in cancer are actually undergoing trials for treatment of COVID. And an example would be a drug like ibrutinib, which is used to treat CLL. There are many reasons to think that could be beneficial to COVID, and so some of the cancer drugs may be protective. So the risk for cancer patients could be modified by what they receive.
Thank you both for sharing what Mayo is doing to lead the way when it comes to addressing COVID and to limit the exposure and precautions for people to continue their cancer treatment as needed. Wondering if, so we've heard that there was a pause in some of the active treatment cancer care, but now everything is back on and moving forward. Is that what I hear you saying, Dr. McWilliams?
Yes, Chris. So for the past several weeks, we've ramped the practice back up. Our chemotherapy and radiation never really paused even because patients really need to stay on schedule. Things that were paused were there were some surgeries where a patient could, many of our surgeries now, patients are getting therapy beforehand, like chemotherapy or radiation, and chemotherapy might have been extended a little bit beforehand, or we found ways to make that work. Some of the procedures were paused. And then also what we call surveillance patients, where they might have had that tumor removed previously and they're just getting their scans to make sure everything's okay. Some of those were spaced out a bit as well. But, you know, by and large, for many cancer centers around the country, things are kind of getting back to, you know, more normal. It probably won't be back to the way it was before, but more normal and getting people the care that they need. Absolutely.
And the other thing that we as an institution are beginning to emphasize is for people with chronic medical conditions, not having medical care for 3 months is not a great idea always. So because of what we've been through recently, it's probably important that many of patients with chronic medical care, including cancer, do come back and do have their appointments to get back on their regular monitoring. And so Mayo and many other sites have created a lot of safety precautions in place to protect you and your families when you actually come for that medical care. So I'm not up to date on the totality of this screening, but everybody who enters the building is screened for possible symptoms and possible virus shedding, and the appropriate infection control precautions are in place. We're limiting the number of people who are in waiting rooms, so you won't be in close proximity to other people. So your chance of getting disease when you come for medical appointments is quite low, and we think very safe.
That is a really important message. We're seeing a lot of folks definitely putting off any kind of health care, including cancer screenings during this time. And that's really concerning to us because we know our population has too many late stage diagnoses. And so would either one of you want to give a message about where patients are when it comes to cancer screening? Is this something that still needs to be addressed, or is it something that should wait?
That one. So yeah, our practice, cancer screening did take a pause as well briefly, but we're ramping that back up for the very reason you described. We're very concerned as a cancer community that we are going to see more advanced cancers presenting because people are afraid to go get the care that they need. So whether it's screening, whether it's bringing a symptom to the attention of their physician, that would then work up to potentially be cancer. So I do think it's important. We have learned a lot as a medical community on how to lower risk for transmission. So I think that the fear that people have of going to the doctors or going to the clinic or going to the hospital, the risk of transmission, as Dr. Badley said, is very, very low. And we are doing everything we can to protect our patients to allow those things that are also really important. And that, I've seen that in the news a little bit more lately as far as the other non-measured effects of COVID and the effects on other aspects of our medical care. I think it's very real and very important consideration.
Thank you.
One other thing I might add, as we've had to think more creatively about how we do care, one of the things that was also paused for a period of time was our clinical trials in cancer, and that's how we improve our care. That's how we improve our outcomes. And because so many, we didn't know risks and we didn't know transmission to other research staff, and we were trying to have not as many people come into the medical center as possible early on, a lot of our research trials either shut down or paused temporarily or to try to mitigate that risk. At the same time, the National Cancer Institute, who oversees many of these trials, allowed for research visits, which before had to be in person. A lot of times if you're on a trial, you had to go to the doctor more frequently and get more testing than you normally would. But they allowed those to be phone visits or remote visits and things like that. And so, as we've gone on, we've reopened now essentially all of our trials. We know how to handle it as safely, we think, as far as minimizing risk to staff for doing those extra testing. But at the same time, we think this might be an opportunity to reach out to patients who maybe live too far away from the cancer center for trials in the past, and coming back on a once or twice a week wasn't practical if you're from 8 hours away. We're hoping that as time goes on with this crisis, we can leverage that ability to do telemedicine, video medicine, into allowing more patients to participate in clinical trials, especially the American Indian community, who are historically underrepresented in cancer trials. And we think it'd be very important to take advantage of that opportunity to reach out and give opportunities to these patients.
Thank you for bringing that message up, because that certainly is an issue that many of our rural tribal communities face. There's a question that came in asking if you're finding patients responding well to the telehealth opportunities.
Yeah, in my experience, yeah, absolutely. I think we've been able to have good conversations, interactions with patients that previously they might not have been able to come for a face-to-face referral. People who are feeling quite ill or are worried about their risk of travel or having to get on an airplane. So enable us to extend our ability to care for patients from further away. We still think that it's not a total replacement for face-to-face care, and there will be a need for people to come get certain scans or that physical examination or get a procedure, but as a part of care, I'm pretty convinced it's here to stay. I mean, there were a lot of barriers that to state lines and licensure issues that have sort of melted away during this crisis, and we're hoping they stay melted away, because I think there are a lot of advantages to being able to reach out to patients who are aren't physically on campus in a timely way, and I think care can be more efficient, but it's a balancing act of all of the above.
I'm really glad to see these advances happening both at big institutions like Mayo Clinic, as well as during this COVID epidemic, we've seen many tribal clinics. I was sharing before the call started that we're seeing many tribal clinics now using telemedicine and making it work within their small communities. And so it's really important when we think about cancer across Indian country and how do we increase that access to care.
And non-cancer as well.
Yes, and non-cancer. I have a bubble. Thank you for reminding me to spread that.
I think maybe another question for both Dr. McWilliams and Dr. Badley is participating in research, and the thought of participating in research can be scary. And what are some things that a patient can think through with their provider? In particular, it may not be that trial is available at their site, but that they would be partnering and coming to another site to participate in that. What are some things that they can think through or need to think through as they're making that decision so they're more comfortable with that decision?
Rob, do you want to start or do you want me to?
I'll take it from a cancer standpoint if you want to take it from a ID standpoint. Certainly for trials for our patients, one advantage to participating in a trial is you may get access to medicines you wouldn't otherwise have access to. So cancer patients, usually our treatments for cancer are good, but not good enough. And we always want to make them better and have our outcomes be better. And so a clinical trial is a great way to be able to get access to medicines that might be the next great thing. And so that's how we advance our knowledge. I've had many patients tell me that their motivation for clinical trials is it may or may not help me, but it's definitely going to help the next guy. And so I think that motivation of altruism and looking out for our communities and as a whole, and how can I help other people like me years down the road, and that can be very helpful for participation in the trial. Also, a lot of times, you'll get extra, testing. Sometimes that's a good thing, sometimes not a good thing, but you're watched very closely on the clinical trial. And so people really have, a strong interest. You're not going to get lost in the system. People, know what's going on. They're kind of very monitoring you in a very detailed way. So there's that extra a little bit of monitoring on a clinical trial that patients do get. So there are a lot of advantages, and I think that it's really, again, American Indians are underrepresented. We're aware of that. We need to figure out ways to make sure that those are more accessible to this community and to enable people if they want to participate.
Echo every comment. A few additional comments. So I think COVID has brought to light the existence of poor science. So there's a lot of news reports of take this drug because my brother took it and he got better. That's not the way to advance therapies. What is the way to do advanced therapies is through controlled trials. And many centers have them. Because Mayo's big, we tend to have more. It's not to say that what we have is better, but we have more and we have more options, and it does advance the science. It does improve care of patients in the long term. It may or may not help individuals, and it definitely, especially against COVID and other cancers, allow access to therapies that you wouldn't have access to also. We completely understand that medicine and science are a different language, and many people are overwhelmed by having to make decisions about a subject they're not fully confident in. But know that our study teams and our study coordinators, their main reason for being your point of contact is to answer all your questions always and anytime. And so if concerns come out, we're always there to help answer your questions. And if you decide to stop at any time, you can. I do know that for some Native American communities, there are concerns about genetic testing. And so it is possible to consent to a trial and explicitly state, I don't want to have genetic testing done. So most study teams are flexible. You can ask specific questions that you want. And it's how we move the field forward. And, you know, going back to COVID, 3 months ago, we had no therapies that work. Now we have one that we know works. And I think we'll have others soon as well because of the existence of clinical trials.
I think to add, thank you so much. I think to add to that, can you describe, many on the call are tribal providers. Can you describe how the tribal provider partnership is with the PI and how we maintain that opposed to taking on their care, but partnering in that care? Maybe speak to that.
You want to start, Rob, or do you want me to, or how do you want to do it?
Why don't you start with this one, Andrew?
Okay. So taking care of a patient takes a team, and it takes a team within Mayo, and it takes a team outside of Mayo. And so our study teams will communicate with the primary care providers no matter where they're located. And as concerns come up, as possible complications come up, as successes come up, there's always the availability to interact and communicate with the study teams. And in my day job, which I haven't been in for 3 or so months, but in my day job, I was involved in a lot of other clinical trials. For COVID, I oversee all of them, but I don't participate in any of them. You know, I spend a lot of my time talking to primary care physicians about the studies we're doing. So it truly is a partnership. Oftentimes patients will want to have the input of their primary care physician before deciding to participate in the trial. And we're happy to engage and have those conversations as well. Rob?
Sure. So it's very similar issues on our side for a lot of our patients who maybe participate in a clinical trial at a Mayo Clinic site who might live outside of town or farther away. A lot of times they'll, you know, if they have complications, they're seeking the care of their primary physician or an oncologist in their community. So we oftentimes will partner with those providers to be able to you know, inform them what the patient's on, maybe if the side effects or the effects that the patient's having are related to the study or not, and then instruct the patient and whether or not to hold medicine or what they need to do on the clinical trial. So the communication is really key. And I think that, you know, especially times with COVID and, you know, things like that where things are rapidly changing, the communication is really crucial. I'd say that's one, you know, looking at silver linings here, I think that's one aspect of all of this that's been really heartening is that, you know, this is a worldwide pandemic and we have really worked on communication and talking with each other as large communities. You know, things sometimes seem far away, but, you know, you have hotspots of the outbreak in New York City and then, you know, in the Navajo Nation. And so, you know, it's really affecting us all in different ways. So I think people are, you know, we've gotten better at reaching out to each other and as a medical community and learning from each other and having this communication. So I think that's the key. I think if a patient's on a study, whether it's an antiviral or a cancer study, and the local provider has questions, you know, we would love to hear from them.
Thank you both for addressing those issues. So many issues today. My page on my notes is jam-packed. I'm really excited about that role between the Cancer Center and the primary care providers, how you all work together to support the communities, and then understanding that when we start talking about genetics, in clinical trials or in research in our communities that can make people very nervous because of the history. And and yet some tribal communities are doing some really great pharmacogenic research. And so it really, it matters who controls that data and what the trust and relationship is. And so there's some big promise, we know, in that type of research. And so, and then just really exciting about the therapies that you talked about, and the understanding the virus and the immune response. That's so important. And then understanding how it plays a role across different groups. So I really want to thank you for bringing these issues up, and want to give an opportunity, because we have your brilliant brains on this call today. If you have some final words of wisdom that you want to leave us with, to really support and encourage tribal communities that may be bracing themselves for an outbreak, or maybe in the midst of an outbreak, when already dealing with numerous chronic health conditions in their community.
So a few thoughts. So it is increasingly apparent that the sooner infected individuals get care, the better they do. So that's advice point number one is if you're ill, get tested and get into a pipeline for treatment. Number two, not all hospitals in the US have access to clinical trials. Today, there are no approved therapies for COVID. I think there will be soon. So as you are able, I'd encourage people to investigate going to centers that do have clinical trials. And then the last comment I'd make is that if some benefit can come from this global pandemic, I hope it's three things. So we are responding better to COVID than we did to HIV, because there have been decades and decades of sustained biomedical research funding. And I hope that that continues. Number two, we were not optimally positioned to implement our public health interventions. And that occurred for a variety of political reasons. And my hope is that this will point to the need to continue to support and endorse and fund public health for the next epidemic that comes along. And then the last comment is, so many people are searching for a vaccine for COVID now, and I agree that will be a great thing. But I point out that we have a lot of really good vaccines right now that not everybody is taking. And so with the recognition that vaccines are beneficial, I hope that everybody listening to the call today and everybody begins to take those vaccines that we know are effective, like the flu vaccine. And there could be a intersection between patients with flu-related disease and possibly on top of that COVID-related disease. And if you can minimize the impact of flu, you should be able to minimize the impact of both diseases together. So hopefully everyone will take their flu shots and every other recommended vaccine that's out there.
I just have 2 points to make. One would be, what we talked about a few times is medical centers have learned a lot about COVID and how to minimize risk to people going there. So, going to the doctor when you need to, if you have symptoms, to get checked out is important. And if you have concerns about safety measures or what they're doing, ask. I mean, we're all open. So if you want to know what your provider is doing to protect you from COVID, you can ask. And many medical centers can tell you right then and there what exactly they're doing to minimize that risk. The second is we are learning more rapidly about this virus than any other virus. And to the point where medical journals would get a paper and then they publish it within a day or two just to get the word out there. the predictable effect of that is some of these papers are kind of running into challenges and issues and problems with data. And so it's not that science doesn't work or shouldn't be trusted. It's that how science works is the first paper suggests a signal, and then you do the randomized clinical trial, and that gives you the real answer, and that just takes longer, but it's more definitive. And it's just seeing things in rapid action. Everybody means well, everybody wants to get the word out there and trying to get these things, but it leads to, when you're reading the literature or looking at the news reports, it seems like, well, this drug works, now it doesn't work, and it's all confusing, and it leads to a lack of trust. And in reality is the science on all these clinical trials, as Dr. Badley has said, is, when the randomized trial come out, that's the gold standard, and that tells you, we did this in a scientific way, and this drug definitely works or definitely doesn't, and exactly what it can do. And so it's hard as a layperson to sift through that. I know our providers on the call are going to be much better at being able to sift through that information, but it's predictable. Everybody means well. No one's trying to put false things out there, but we're just rapidly trying to learn from this as fast as we can.
I think I would add to those comments that we have a number of trials and we have a number of opportunities and various experts, but there may be tribal providers that have ideas and expertise that they want to collaborate with us as well, and we're very open to that for cancer or COVID or other topics. And I think that because we've had to function very differently, all of us across the nation, across the world, the silver linings Dr. McWilliams was saying is that in some ways that has accentuated our ability to maybe collaborate and work together through different venues. So we welcome any ideas or any potential projects that individuals might want to bring forth, and for consideration on how we might partner.
Thank you, Jenny, for bringing up that important point. Definitely the healthcare providers across tribal and IHS clinics know their communities, know the challenges, and are often very eager to partner with other experts to be able to move forward on issues. So I expect that you will get some folks reaching out after this call. And I want to, as we wrap up here today, I really want to thank Dr. Badley and Dr. McWilliams for sharing your wisdom and with us today. It's been a pleasure to meet you both, and I can see your passion for what you do in infectious disease, Dr. Badley, and in cancer control, Dr. McWilliams. Thank you both for all that work that you do to protect people and to collaborate and have a fun conversation at the same time. And thank you, Jenny, for all of your work to organize and make this happen today.
We are very happy to be co-host, and we thank the American Indian Cancer Foundation for arranging this and for inviting us to attend, and for you for facilitating it. I think this is really valuable, and again, it helps with that bi-directional communication. Today, just because of the format, we could address questions electronically, but happy to follow up with phone calls or address additional questions if there's any need for that.
For sure.
Thank you all very much.
Thank you. Have a good day.
Bye now.